Yes, antiphospholipid antibody syndrome, APS, can present with central retinal artery occlusion as an initial manifestation. APS is a prothrombotic disorder associated with arterial and venous thrombosis, and CRO is a potential arterial thrombotic event in this context. Retinal artery occlusion can result from the formation of arterial clots, which impair blood flow to the retina and can lead to sudden, painless loss of vision. In some cases, CRAO may be the first clue of an underlying systemic thrombophilic disorder like APS, especially in young patients without traditional cardiovascular risk factors. Therefore, it's essential to evaluate for APS when patients present with CRAO, particularly if they have a history of miscarriages, deep vein thrombosis, DVT, or other thrombotic events. Testing for antiphospholipid antibodies, APL, such as lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein 1 antibodies, is recommended in these cases. In the case of acute central retinal artery occlusion, CRAO, associated with antiphospholipid antibody syndrome, APS, immediate intervention is critical to minimize permanent vision loss. Treatment includes 1. Ocular treatments, immediate lowering of intraocular pressure. This can be done using medications such as acetazolamide, topical beta blockers, e.g., timolol, or ocular massage to dislodge the embolus. Anterior chamber paracentesis, occasionally performed by an ophthalmologist to lower intraocular pressure rapidly. Hyperbaric oxygen therapy or carbogen inhalation, 5% CO2, 95% O2, may improve oxygenation to the ischemic retina if available early. 2. Systemic anticoagulation. Anticoagulation therapy with heparin or low molecular weight heparin, LMWH, should be started promptly, especially in cases linked to APS. Transitioning to long-term anticoagulation, usually with warfarin, with an INR target of 2 to 3, is typically indicated after initial stabilization. In patients with APS, treatment with anticoagulation is generally lifelong to prevent recurrent thrombotic events. 3. Thrombolytic therapy. Although controversial, some cases of CRAO, particularly in very early presentation, within 4 to 6 hours, may benefit from intraarterial thrombolysis using drugs like tissue plasminogen activator, TPA. However, this is not always widely available and carries risks. 4. APS management. Along with anticoagulation, managing APS includes regular monitoring of antiphospholipid antibodies and treating associated risk factors such as hypertension and hyperlipidemia to reduce the risk of further thrombotic events. Time is crucial in CRAO, so initiating treatment promptly can sometimes help restore some vision, though the prognosis often depends on how early treatment is started. Steroids and steroid-sparing drugs generally do not play a significant role in the acute management of central retinal artery occlusion, CRAO, related to antiphospholipid antibody syndrome, APS, as CRAO and APS is primarily a thrombotic event rather than an inflammatory one. However, in specific scenarios, these drugs might be considered. 1. Steroids. Steroids are typically not used in acute CRAO unless there's suspicion of an inflammatory cause, such as giant cell arteritis, GCA, which can also present with CRAO. In GCA, high-dose steroids are essential to prevent further vascular occlusions, including vision-threatening events in the other eye. In APS, there is no robust evidence to support the routine use of corticosteroids for managing thrombotic events like CRAO, unless other systemic inflammatory conditions coexist. 2. Steroid-sparing agents. Steroid-sparing immunosuppressive drugs, e.g. azathioprine, mycophenolate mofetil, or rituximab, might be used in catastrophic APS, CAPS, or severe cases of APS where inflammation or autoimmunity is driving persistent thrombosis, but these agents are not first-line treatments for acute thrombosis. In some APS patients with coexisting lupus or other autoimmune disorders, immunosuppressive therapy might be necessary to control the underlying disease process and reduce long-term thrombotic risk. However, they are adjunctive to anticoagulation and not used in acute CRAO treatment itself. Conclusion: for acute TRAO in APS, the primary treatment is anticoagulation to prevent further thrombotic events. Steroids and steroid-sparing drugs are not typically part of acute management unless another inflammatory condition is present. Long-term management of APS involves anticoagulation rather than immunosuppression unless there are overlapping autoimmune features. Disease-modifying antirheumatic drugs, DMARDs, including both conventional and biologic agents, do not have a direct role in the acute management of central retinal artery occlusion, CRO, associated with antiphospholipid antibody syndrome, APS. CRAO in APS is primarily a thrombotic event, and the cornerstone of treatment is anticoagulation, not immunosuppression. However, DMARDs may have a role in certain scenarios involving APS when there is an underlying autoimmune or inflammatory component, particularly when APS coexists with other autoimmune diseases like systemic lupus erythematosus. Specific roles of DMARDs in APS. 1. When APS is associated with autoimmune conditions. APS with systemic lupus erythematosus. In cases where APS coexists with SLE, DMARDs like hydroxychloroquine, HCQ, are commonly used to manage lupus. Importantly, HCQ has been shown to have antithrombotic properties, reducing the risk of thrombotic events in both lupus and APS patients. Other DMARDs, e.g. methotrexate, azathioprine, or mycophenolate mofetil, might be used to control underlying autoimmune conditions that are contributing to the prothrombotic state, but are not directly treating the thrombotic aspect of APS itself. 2. For catastrophic APS, CAPS, in catastrophic APS, which is a rare but life-threatening condition characterized by multiple simultaneous thrombotic events, DMARDs like rituximab or cyclophosphamide may be used in conjunction with anticoagulation, plasma exchange, and steroids. This is because CAPS often involves a hyperinflammatory or immune-mediated process. 3. Preventing recurrent thrombosis. Although not routinely used for anticoagulation, hydroxychloroquine has been shown to reduce the frequency of thrombosis in APS, especially in patients with lupus. It is often used as an adjunct therapy in those with autoimmune overlap. Other immunosuppressive DMARDs might help reduce thrombotic risk by controlling systemic inflammation in patients with APS secondary to autoimmune diseases. Conclusion: DMARDs do not play a direct role in treating acute CRO and APS. However, in cases where APS is secondary to an autoimmune condition like SLE, DMARDs, particularly hydroxychloroquine, may help prevent recurrent thrombotic events as part of long-term management. The primary treatment in acute APS-related CRAO remains anticoagulation. The prognosis of central retinal artery occlusion associated with antiphospholipid antibody syndrome, APS, is generally poor in terms of visual recovery, as CRAO typically causes irreversible retinal ischemia if not treated very quickly. Prognosis largely depends on how quickly treatment is initiated and whether any vision is restored during the acute phase. Here are the key factors influencing prognosis. 1. Time to intervention. CRAO is a true ocular emergency, and irreversible damage to the retina can occur within 90 to 100 minutes due to lack of blood flow. Early intervention, such as reducing intraocular pressure, ocular massage, or hyperbaric oxygen therapy, may improve the chances of some visual recovery. However, in most cases, recovery of vision is limited even with prompt treatment. If intervention occurs beyond a few hours, the prognosis for significant visual recovery is poor. 2. Extent of retinal damage. The longer the retina remains ischemic, the greater the extent of permanent damage. Most patients with CRAO experience profound and permanent loss of vision in the affected eye, often retaining only light perception or hand movements. If a cilioretinal artery is present, a small artery that supplies part of the retina and can be spared in CRAO, patients may retain a small island of central vision, improving prognosis slightly. 3. Antiphospholipid antibody syndrome, APS. The presence of APS increases the risk of recurrent thrombotic events, including further arterial occlusions in the retina or elsewhere, e.g., stroke, myocardial infarction. Without adequate long-term anticoagulation, patients with APS are at high risk for recurrent episodes of vascular occlusion, further worsening their visual and systemic prognosis. With proper anticoagulation therapy, the risk of recurrent CRAO or other thrombotic events can be reduced, but the long-term prognosis depends on adherence to treatment and ongoing management of APS. 4. Systemic risk. APS is a systemic thrombotic disorder, and the occurrence of CRAO may indicate an increased risk for other serious thrombotic events, such as stroke or myocardial infarction. Prognosis can be affected by how well these risks are controlled with anticoagulation and other preventive measures, e.g., controlling cardiovascular risk factors like hypertension, diabetes, and smoking. Overall visual prognosis. Most patients with CRAO, especially when related to APS, have poor visual recovery, and the vision loss is typically permanent. Long-term systemic prognosis can be better if APS is managed effectively with lifelong anticoagulation, reducing the risk of future thrombotic complications. In summary, the visual prognosis of CRAO and APS is poor, but with appropriate systemic anticoagulation and management of APS, the risk of further thrombotic events can be reduced, improving the patient's overall prognosis.